So good evening all, and welcome everyone to the PG case discussion series conducted by IRIA Kerala in connection with Genomed. And this month actually we are on head and neck imaging, and the faculty talk as well as the discussion, PG discussion will be in connection with head and neck imaging. And for this, I welcome Dr. Gomadi Subramaniam, President Kerala IRIA, Dr. Rijo Matthew, Secretary Kerala IRIA, and Dr. Ramesh Shanai, Program Coordinator. And today, our faculty is Dr. Rajesh Kannan, he is Professor in Amrita Institute of Medical Sciences, Kochi. Hearty welcome, Dr. Rajesh Kannan. And now, over to Dr. Rajesh Kannan for the conduction of this PG discussion. Thank you.
Thank you, Dr. Venu. Good evening, all. Welcome, participants. So we'll move to the PG case presentation. Today topic is head and neck imaging. So we'll start with the first case. Dr. Sanidhya, you can share your screen.
Yes.
So today we have three interesting head and neck cases. So we are going to discuss how to approach head and neck lesion. Yeah, so you can start.
Okay.
I request everybody to listen to this carefully, and if anyone have any doubt, please write your queries in the chat box. Okay, so it's better I can see only one, so don't send it in Q&A. Please send it in a chat box so that we'll discuss it at the end. Okay.
So today's my case is about a 69-year-old male presenting with large painless neck swelling. And the lab parameters were taken for this patient. The total count was absolutely normal. Inflammatory markers were normal, and on palpation it felt like a mobile, non-fixed soft tissue kind of a swelling. Lateral cervical spine radiograph was taken for this patient, which shows prevertebral shadow widening at multiple levels, extending from C2 to the inferior end of C7 till what we can see, and it is displacing the pharynx anteriorly. So,
Dr. Sanidhya, can you tell me when to call it as a prevertebral soft tissue widening? What is the criteria you'll use?
Yes, sir.
On an X-ray?
Yes, sir. Yes, sir. So basically at each vertebral level, there are certain cutoffs. They are not definitive, but we can predict the C2, C3 level more than 7 mm widening, and C6, C7 level more than 21 mm widening. More than 21 mm, we can call it as widening on a cervical spine radiograph, sir.
Yeah, so how will you measure it? But 10 mm, 20 mm and all?
Right from the anterior spinal line till the pharynx, sir?
Yeah. But how will you measure that? Whether what you are measuring is a 10 mm or a 20 mm and all, given in an X-ray, you can't use the scale because you have a different types of images and all. So looking at that image, so how will you say roughly there is a widening of the prevertebral soft tissue widening? Is there any other set of landmarks or the some reference points? So only based on that, mostly X-rays, unlike a CT, where we can measure it when you have a cursor. Whereas on X-ray film, we cannot measure it.
Okay.
So what is the any reference point in reference to say vertebra? So what is the maximum allowable size? See, at any level, it should not extend the height of the vertebra. Okay, so that is usually taken as one of the landmark. So here, if you look at it, unless you should not take any collapsed vertebra, a normal vertebral height. So if you look at the prevertebral soft tissue, so maximum it can be the height of the vertebral body. Okay, so it is
Okay.
very important, and especially when you are looking at that X-ray, you cannot measure 10 or 20 mm and all. Okay, so
Okay.
we need some reference image or a reference structure, to compare it. Okay, fine, yeah. So what do you think? What could be the cause for this?
So the soft tissue thing which I'm able to see is a bit darker than the muscle, sir.
What
It
are the
looks
common causes of prevertebral soft tissue widening?
Sir, could be a retropharyngeal abscess
Okay.
or a retropharyngeal hematoma.
Hmm.
Then can be lymphoma.
Hmm.
Could be a lipoma. Like basically, the space has retropharyngeal space. Usually has fat and nodes when it comes to suprahyoid segment. So whatever involving fat and node can be there. Whereas the infrahyoid usually has only fat, sir. So depending on the content pathology, we can predict, sir.
Okay, so now when you have a lesion like this, when will you suspect an abscess, prevertebral abscess? So what are the things you have to look for?
So for an abscess, we might see air spaces within air fluid level, or like the history can help.
Okay. Now imaging wise, X-ray wise, what are the things you have to look for when you are suspecting an abscess? Air fluid level is one, yeah, but usually rare. Now will you look for the cause?
Yeah, so basically a penetrating injury can cause it.
Okay.
So we can look for any history, like for any features of trauma or anything. Then we might also see the prevertebral space involvement. It will be difficult on an X-ray. So something like spondylodiscitis, infection spreading into the retropharyngeal
Yeah.
space.
So basically, you have to look for spondylodiscitis. So what feature you have to look at it to say whether it's spondylodiscitis?
On X-ray.
No, basically, you have to look at the vertebral body and the IV disc, isn't it?
Yes, sir.
Yes, so you have to, whenever you are seeing any prevertebral soft tissue, then you have to look at the vertebra. Is there any vertebral collapse, or under the you have to look at the intervertebral disc, whether any disc is involved. Okay,
Yes,
so any features of discitis, as well as you look for any foreign body, either a fishbone, a radiopaque foreign body, which is causing abscess. So these are all the common things. Similarly, you can look at the epiglottitis, any infections there. So whatever maximum things possible you can see. Similarly, when you are suspecting a trauma related things, then you have to see whether the vertebral lining is, alignment is correct. Is there any fracture? So all those features you will be looking for. So these are the common things which will produce prevertebral soft tissue widening. Okay.
Yes. So this were our findings. It looks like a long segment uniform widening of prevertebral shadow in the form of some lucency, which looked darker than the muscle.
Yes.
I could not see any obvious intralesional calcification or air fluid level on a radiograph. There was no cervical vertebral collapse. Few marginal degenerative changes, osteophytes were seen. So the previously what I mentioned, the cutoffs for at each level are mentioned down. So basically normal prevertebral shadow at C2, C3 level less than 7 mm and C6, C7 level less than 21 mm is considered to be normal.
Can you show the image again and so that lucency, how will you say it is lucent and it's not like an usual abscess or a hematoma?
It looks bit darker, sir. Then the muscle also and.
So the muscle density and the lesion density, which one you are comparing? Do you have RF? Can you use the pointer?
Yeah, 1 second.
So that is a lucent and compared to what?
This one, sir.
Yeah. Okay. Muscle as well as you can compare it with the submandibular region, submandibular gland soft tissue. So compared to that, the density, whenever you are seeing a lesion, you have to look at the what density it is. Is it a air density? Is it a soft tissue density? Is it a bone density? Or is it a metallic density? So on X-ray wise, It's not just the shadow, and its density also is important. So you feel that it is more loosened than the soft tissue. So what does it mean?
So could be fat.
Yeah.
But we need a cross-sectional imaging.
So what else can be darker than the soft tissue? One can be fat then? See, only two structure is darker than soft tissue.
Air can be there, but it doesn't look like that.
Only two structures. So either it has to be fat or should be air. One is air compared to the air, it is not as dark like air.
Yeah, sir. As compared to the pharynx, it's less.
So then still it is possible if there is a mixture of air and the soft tissue.
Yes.
Okay. So that's what you have to explain. See, you know the finding, you know the answer, but you should know what how to answer in an exam, for a particular question. Okay.
Yes.
So don't think that these are all very silly questions. So yeah, everyone knows now what structure will be darker than soft tissue. So, but when you should know, you should take that clues when somebody is giving the clues and all, so that you can lead to a right diagnosis. Okay. Yeah.
Yes.
Fine. So what else was done?
So our working differentials were this, sir. Basically a retropharyngeal abscess, hematoma, lipoma, lymphoma, and rarely laryngeal tumors or cervical adenopathy. So we got a contrast CT axial sections where we can see a fairly large fat density lesion involving the retropharyngeal space, extending down from the suprahyoid retropharyngeal space, extending down into the infrahyoid retropharyngeal space and going up to the mediastinum. This reached around T3, T4 vertebral level, sir. The lesion did not have any calcification. It didn't even show any vascular infiltration or the pharyngeal infiltration. It was extending on both sides, but no definite evidence of perivertebral space involvement on a CT scan. And the oropharynx was a bit deviated to right side. So
yeah, see, the important thing is whenever we see any retropharyngeal or a perivertebral lesion, always we think either it's an abscess or a hematoma. Okay, yes. But always you have to think beyond that also. Like these are all very rare things, and so always you have to look at the density and you have to compare it with the normal structure, whether it is an X-ray, ultrasound, CT, or MR. Okay, so this is basically a large lipoma. Okay, so mimicking like a perivertebral collection. Okay.
Yes.
You can go ahead. Yeah.
1 second. So the findings were a large non-enhancing homogeneous fat density lesion involving the retro and posterior parapharyngeal space extending into mediastinum, reaching up to almost carina, D4, D5 level. Lesion was seen displacing the common carotids and IGV laterally. However, there was no evidence of vascular compromise or infiltration. No areas of calcification or soft tissue lesion within the lesion. One working differential, close differential would be a well-differentiated liposarcoma. So biopsy was done for this patient, came out as a lipoma.
So what are the imaging difference between lipoma and liposarcoma?
So liposarcoma can be of various types, sir. Can be a well-differentiated, can be a de-differentiated, can be a pleomorphic liposarcoma. So basically, it's more soft tissue density lesions within the lipoma, infiltrating mass, calcifications point us more towards a de-differentiated one. And well-differentiated one will be predominantly fat density, sir. Less than 1 centimeter soft tissue can be there, but the definitive diagnosis comes from HPE only, sir.
Yeah, so that is okay, good. In fact, Sanidhya was not well and he got admitted yesterday in casualty and all. So we couldn't able to prepare many things, but he really did well. Thank you, Dr. Sanidhya, for that
Thank you,
effort.
Thank you.
So we will move on to the next case. If there are any queries, please write it in the chat box. We will discuss. Can you stop your screen, sir? Dr. Zuhu, can you start your presentation?
Yes.
Can you keep the chat box on? Soumya, someone says chat box is off.
No, sir, it's working only.
Okay. Yes, you can start.
Good evening. I'm going to present a case of sphenoid sinus mass. A 46-year-old female initially presented with blurring of vision for 2 months. Clinical examination revealed a polypoidal mass in nasal cavity. So we have done MRI from our institution. This is the T2 axial images of the same patient, which revealed a markedly hypointense expansile lesion involving the sphenoid sinus, which is bulging into the ethmoid air cells. And in the superior sections, it is also involving the orbit bilaterally. You can also see a T2 bright opacification of.
Can you use pointer,
maxillary
please?
sinus.
Can you
Yes,
use
sir.
pointer and show the lesion?
This is the T2 hypointense lesion involving the entire sphenoid sinus, causing expansion of the sphenoid sinus. It is extending anteriorly into the ethmoid.
Why do you say this lesion is in the sphenoid sinus? Why not in the cellar? How will you differentiate a cellular lesion from a sphenoid sinus lesion?
In axial images, it is difficult to differentiate it from a cellular lesion. However, we have coronal sections. So in
No,
that
axial only I am asking how to differentiate. Can you able to see the cella and see earlier days no, there were no coronal imaging and also only axial CT scans were available, but even with that time now people used to differentiate, isn't it? So so the axial only, don't move. So what to look for?
There is no supracellular extension. The optic
Okay.
chiasm is not wide displayed. And
yeah, that is the supracellular cistern level. Almost we can see the pituitary stalk and all that, that slice. Okay.
yes.
Where will be the pituitary gland in that section? Can you show? Second image, yes, that is the region where, and if you go down and the same next previous slice, first slice, yeah, that will be the cell under the pituitary gland. No, okay. Yes, so axial sections, it is looks like it is difficult to say, but whatever possible information you can get, you can explain those. Okay. Yeah,
Yes.
go back to the previous set of images. Yeah, so when you see I mean image like this, because you have seen rest of the images, so you are saying that there is a mass. Otherwise, what you are seeing is just a widening of the bone there. Okay, we are not seeing any mass. It is appearing basically darker on T2. So some sort of a widening of the lateral wall of the we can say sphenoid sinus. So when you see a lesion like this, what are the things you will think of?
We can think of sinusitis. It can be sinonasal carcinoma. It can be any mass arising from the sphenoid. Then mucocele or mycetoma, fungal mycetoma. These are the common DDs that we can expect in a lesion like this.
Yeah, so you are discussing about the lesions involving the sphenoid sinus. Here, in addition that it is the lesion is appears very dark, on this sequence. So, what does it indicate? So, what type of tissue we are dealing with?
It can be a fungal component, sir, fungal hyphae. And it actually mimics air. It's very hypointense.
Okay, what else? What else will appear dark on T2 weighted image, which can occur in the sphenoid sinus? What about any bone tumors?
Yes, sir. Ossifying sinus fibroma.
Okay, yeah. Yeah, see, there are a lot of bone tumors like osteoblastoma, ossifying fibroma, chondroblastoid fibroma. So there are so many bone tumors are there. So any bone tumor going to appear dark on T2 weighted image. Okay, and any high protein material. Okay, so just retention cyst. Usually don't so much expand cell. Now any polyp having a high protein content can appear dark. Okay, and what about mucocele? Will it appear dark on T2?
Mucocele appears bright on T2.
Yeah, so again it depends on the protein content. Usually
content,
in a mucocele the protein content won't be so high. Only if the if you look at the protein content under the T2 signal, normally if the protein content is very low, it will appear bright. As the protein content increases, it become more and more darker. Okay, so when it is very high, then it will almost will be black.
Yes, sir.
Okay. And what about hemorrhage? Can it appear dark?
Yes, sir.
Yeah. So which stage of hemorrhage will appear dark?
Chronic can appear dark, sir.
Okay. Then any other stage of bleed will appear dark? Only chronic will appear dark? See, there are many stages of hemorrhage, starting with the deoxyhemoglobin, methemoglobin. In that methemoglobin, we have intracellular and extracellular methemoglobin, then hemosiderin. Okay, so hemosiderin will be dark, and the acute stage, deoxyhemoglobin and the intracellular methemoglobin, that also will be dark. Okay, so only the extracellular methemoglobin and the oxyhemoglobin will be bright on T2. Okay, fine. So any lesion with a completely hemorrhagic content also can appear dark like this. Okay, so you have to know what are all the different tissues which can come there and the DDs for that. Okay, yeah, move to the next.
This is the coronal T1 images. It shows an intermediate signal relatively hyper intense compared to the muscles. It is not extending into the cella.
Can you show the pituitary gland? Where is the pituitary gland? Which is the best plane to look at that? Previous image. The last image.
Yes, sir.
Yeah, so we can see the optic chiasm, and below that is the pituitary gland, which appears to be displaced superiorly. Okay, fine. But which is the best plane to look at the pituitary gland and the relationship to the sphenoid sinus and the optic chiasm?
At the level of cavernous sinus, where the artery.
Which plane? Axial, coronal, sag, oblique? Which will be better in here? Sphenoid sinus to the pituitary gland, sagittal is better. Okay.
Okay, sir.
Which will clearly demonstrate the pituitary gland separate from the sphenoid sinus. Okay.
Okay, sir.
For optic chiasm, yes, we can look at both cornal and the sag. Okay, so how is the lesion here? Whatever your lesion you are shown appear dark on T2, but here appears bright on T1. So what are all the tissues which will appear bright on T1 weighted image?
In T1, hemorrhage can appear bright, and high protein contain mucoceles in certain tumors, and
Yeah, so these are all the common questions always asked in the exam. So basically, common tissues which will be bright on T1 are the fat. You can see that subcutaneous fat appearing brighter. So protein material can appear brighter. Then blood products appear brighter. But which stage of blood will appear bright? Which hemoglobin? So not all hemoglobin will appear brighter. It's only the methemoglobin will appear brighter, isn't it? So both intracellular and extracellular methemoglobin will appear bright on T2. So if it is appears bright on T1 and dark on T2 in this case, and if it is a blood product, so can you say which type of a hemoglobin it will be? Only one hemoglobin will be bright on T1 and dark on T2. Yeah, which stage of methemoglobin?
Intracellular.
Yeah, yes. So only the intracellular methemoglobin will be dark on T2, bright on T1, whereas the extracellular will be bright on both. Okay. Yeah. So then the other content which can appear bright on T1 are the melanin, can appear bright, and some of the fungal granulomas and all can appear slightly brighter on T1 weighted image. Okay. Plain scan. Fine. Next.
This is the contrast T1 images, which shows a relatively mild enhancement in the periphery as compared to the non-contrast T1 sequences. This is the non-contrast T1 and this is the post-contrast. Some minimal enhancement can be seen in the inflamed peripheral mucosa. There is no intense enhancement.
Suppose if the lesion is appearing so bright on T1 weighted image, and visually sometimes it's difficult to say whether it is enhancement or not. So is there any other method where you can demonstrate the enhancement? So how will you say that there is a, someone says that both appears bright? How can we say that it is more brighter on post contrast? So you can use a subtraction method. Okay. So if you acquire the images in the same matrix under the same FOV without changing the FOV under the matrix size, most of the scanners will allow you to subtract the post contrast from the pre contrast image. So even that, if it is under, patient should not move. That is very important thing. Between the two scans, there should not be any movement, and it is not possible to get that type of quality in the brain scan as compared to the rest of the body. So whenever we have a doubt, what we can do is we can subtract it from the post contrast from pre contrast. So then we can clearly demonstrate is there any enhancement or not. Okay, fine.
Okay,
next. So what do you think with that? After looking at that, yeah, can go to the different diagnosis.
Solitary sinonasal polyp can be a DD. These are inflammatory polyp without any significant history of allergy. And the most common type is androcoenal. If you are doing a CT, we can see a well-defined dumbbell-shaped mucoid density lesion. It is starting from the andrum and extending through the ostium into the nasal cavity and into the nasopharynx. Generally, these are T1 hypo-intense and bright on T2 with only peripheral mucosal enhancement.
Yeah, so this is not a polyp, because generally the polyp won't cause so much expansion, and they won't appear dark on T2 unless it has a very high protein content. They are usually won't have that much protein content, so usually it can appear bright on T1, but not dark on T2 weighted sequence. And generally they won't cause significant expansion of the bone. So here it is not a polyp. Okay, next.
Okay, sir. Sinonasal polyposis. This is a common form of
Same thing, can move on next.
mucocele. Most common expansal sinonasal lesion result from the obstruction of ostium or compartment of septated sinus. And it's most commonly occurring in the frontal sinus, then ethmoid, then maxillary and sphenoid. In CT, it will be an opacified expanded sinus with the mucoid density. There will be enhancement of the peripheral mucosa. It might suggest a mucopyosil. Usually it won't enhance, and if it is enhancing, it will be infected. MR signal varies with the protein-water ratio, generally T1 hypo and sometimes T2, generally T1 hypo and T2 hyperintense.
No. Usually the mucocele will, because of the protein content, many times they will appear brighter on T1 weighted image. Both, it will be bright on both the T1 and T2 weighted image.
Oh, okay.
And how will you differentiate mucocele from a fungal mass?
A fungal mass will be having T2 hypointensity, but mucocele will be having T2 hyperintensity, and there will be peripheral enhancement in fungal sinusitis.
The mucocele also can show the compressed parenchyma can see. Important thing is the mucocele, it's like a cyst, clear fluid, not very clear fluid. It has a cyst, so it will appear more or less very homogeneous. Whereas the fungal mass will be, it won't be so homogeneous. So it is because a solid, isn't it? Okay.
Sir.
Yeah, next.
Allergic fungal sinusitis. This is a severe form of chronic rhinosinusitis with polyposis. Allergic response to fungus characterized by eosinophilic mucin with non-invasive fungal hyphae. There will be opacification and expansion of multiple sinuses with inspissated material. Centrally hyperdense in CT and peripherally hypodense. Expansion of the sinus with bony remodeling and erosion can happen, and hypointense on T2 weighted MRI. Our case is actually allergic fungal sinusitis with sinus expansion, bony remodeling, T2 hypointensity. Mainly it involved ethmoid sinuses more commonly, then maxillary and frontal and sphenoid. It can be unilateral or bilateral, usually right side more than left. May extend into adjacent orbit or cranial cavity. MR findings of allergic fungal sinusitis. T1, it shows variable signal and depending on the water, protein and fungal content. Intermediate to high signal due to low water and high protein content. In T2, it will be hypointense. Centrally, due to dense fungal elements, it can mimic air. And post contrast, the peripheral inflamed mucosa can enhance. Other TDs are sinus ossifying fibroma. Am I audible, sir?
Yes, go ahead.
Okay, sir. Sinus ossifying fibroma. Imaging appearances varies. The classic appearance is thick, bony peripheral ring surrounding fibrous center. This is the fibrous center, and this is the peripheral ossified part. thick bony peripheral ring surrounding it. Expansile mass with soft tissue density, central area surrounded by ossified ring, may be indistinguishable from fibrous dysplasia and osteoma when completely ossified. In T1, intermediate to low signal throughout the tumor. In T2, mixed low and high signal areas. Inhomogeneous enhancement of the fibrous components. MR appearances varies and may appear aggressive. Rare DD sinonasal non-Hodgkin's lymphoma. It involves nasal cavity more than sinuses. The mass with bone remodeling and destruction and extension into sinuses. MR, it will be homogeneous, shows diffuse enhancement, and T2 will be low signal.
This case is not lymphoma. Why?
It is not showing homogeneous enhancement, sir.
Only because of that? No. See, in order to jump into the contrast, see, in a plain scan, it never will be so dark, like a air. So, lymphoma will show low T2 signal. So, when we are saying a hypointense or a low signal, you should know how much low. It will be slightly brighter than gray matter. It will be never bright, almost like a fat or a blood. It will be almost iso-intense to the white matter. It never will be very darker than white matter and all like this. This is almost like a air. No, we are not seeing anything inside. It is not the feature of the lymphoma. Okay, so forget about the enhancement and all. So enhancement sometimes may be difficult to appreciate. Very rarely a lymphoma can bleed inside, even though rare. Okay, so that case difficult to appreciate, but even otherwise it won't have this type of T1 signal or a T2 signal. And it won't cause much bone remodeling. Is usually a feature of a benign entity, and malignant tumors usually will cause the destruction of the bone. That's very important feature you have to understand. Okay. So whenever you see an expansile, scalloping, remodeling, usually indicative of a benign nature. Okay, next.
So our case underwent biopsy from the nasal cavity from the sphenoid posterior part of the septum, and it came as fungal rhinosinusitis. There was inflammatory cell infiltrate with the eosinophil, scattered mucus glands, and thin wall blood vessels. It came as fungal rhinosinusitis.
Yes. So the important teaching point is the masses involving the sphenoid sinus are very common. One is you should able to differentiate a pituitary mass invading into the sphenoid sinus versus a primary sphenoid sinus mass. So first thing you have to rule out that. So you always look at the coronal and the sagittal plane, especially the post-contrast scan, and you should be able to demonstrate the pituitary gland separate from the mass. And the lesions in the sphenoid sinus which can appear brighter on T1 weighted images are the mucocele, fungal mass, or the hemorrhage bleed into the sphenoid sinus. The lesions which can appear darker on T2 include the again fungal mass and the bone tumors. They are all rare, but they are all well-known entities, including the chondrosarcomas, chondromixtide fibromas, ossifying fibromas. So there are so many primary bone tumors we have to keep in mind. And what will be the plain CT finding of a fungal mass?
It will be hyperdense, sir.
Yeah, so linear hyperdense fungal hyphae, if it is there, usually a classical feature, and it can rarely show calcifications also. Yes. Okay, thank you. So thank you, Zugu. It's a good presentation. We'll move to the last case. Okay. Can you stop sharing?
Yeah.
Yeah. I request the delegates to send their queries in the chat box so that we can take it at the end. Yes, you can start with this.
Yes, sir. Good evening, sir, and everyone. Here I am presenting an interesting case of a head and neck space. We have a 36-year-old male who came with the complaints of like slurring of speech and also like altered taste, like metallic taste in the mouth. And on examination, he was having left-sided tongue muscle atrophy and left-sided palatal weakness also. When further investigated, like they have done the CT scan. These are the axial sections, non-contrast images of the head and neck. It shows, I could see a fairly well-defined like hypodense lesion, probably in the like carotid space.
It's not probably. It is in the carotid
Like
space.
like in the carotid space,
Can
because
you
we
use
could
pointer?
see the
Can you use the
Yes, sir.
pointer
Yes,
arrow?
sir. See the fairly well-defined hypodense lesion in the carotid space. That I could say, like, because the parapharyngeal fat is being pushed medially, so it we can tell it as from carotid space. And this I can put that think of the DDs like it can be like a nodal mass. It can be like a nodal mass, or as the carotid space has the other contents of arteries and nerves, it can also be like a pseudoaneurysm or any dissection, or even carotid nerve sheath tumors also a possibility. So when we proceeded with the contrast scan,
No. What are the other conditions? Only you are telling
Other,
it's a
other
nodal mass,
nodal
vascular.
mass, sir, and vascular origin, like,
Okay.
and
Then
even infectious causes, and also like branchial cyst also a possibility. This is
What
almost
else?
showing a fluid attenuation, like almost like a.
Okay. What else possible? What are the other lesions which can occur in the carotid space? Could be carotid body tumor.
Yes, sir. Carotid nerve sheath tumors and also carotid body tumors like like paraganglioma.
Yeah. So those are the common
sir,
things you have to think of. Okay.
Yes, sir.
Fine.
And proceeded to the contrast angio. The same lesion was not showing significant enhancement, and I could see the 1 second. This is the common carotid artery, and I could see this lesion splaying the internal and external carotid apart, and also like partly this might be the like IJV. This is also being pushed posteriorly.
So what is the importance of the splaying of the carotid artery?
So usually the splaying of the carotid artery, we can still a possibility of carotid body tumor, or even the carotid nerve sheath tumors also possibility.
Yeah, see, basically it useful for locating the lesion. Okay.
Sure.
So when we say the splaying of the carotid vessel means we are talking about the displacement of the ICA and the ECA. At the level of the ECA and the ICA, the division from the common carotid, the lesion is extending into that. That is, there are very few structure which will be extending into that. Most common thing is the carotid body is located there, so it will tend to splay it. So sometimes on an axial section it will be difficult to say whether it is just displaced or it is reaching right up to the bifurcation. So best will be looking at the sagittal scan.
Sagittal.
For that, yeah, I will come to that. Are you want to show that? Okay.
Yes, sir. Even in the coronal also, like we could see the lesion like splaying the ECA and ICA. But on sagittal images, the same lesion like is showing the splaying, but actually it is not reaching till the carotid bifurcation. If it was like a carotid body tumor, it will be splaying the EC and ICA like right from the carotid bifurcation.
Yeah, so people should not mistake this for splaying and straight away don't diagnose this as a carotid body tumor. So one is the location, even though it is causing some displacement of the ICA and DCA, still it is not reaching into that point of the bifurcation. Second is the enhancement pattern.
Enhancement.
It is, usually carotid body tumor will enhance brilliantly. Okay.
Brilliant enhancement, but here it is not there. So the possibility of that is less likely, and also the possibility of vascular origin also less likely because we are not seeing a significant enhancement.
Yeah.
So
that will that completely rules out a non-enhancing lesion? Will that always rule out an aneurysm?
No, sir. Like even
if it is a thrombosed aneurysm, so then you have to look for a small focal outpouching. So many times only a neck may be seen and the entire aneurysm may be completely thrombosed. Okay, so but here we are not seeing any type of a neck. So you have to always look very carefully whenever you are seeing a lesion like this. And the other thing is, if it is a thrombosed aneurysm, generally they will be hyperdense on a plain scan. Here it is not hyperdense. It's not an acute thrombosed aneurysm. And can you show the superior extent of the lesion? How far it is extending?
It's almost reaching the jugular fossa.
Yeah. So jugular that is again other feature which is not not seen in a carotid body tumor.
Carotid body tumor.
Okay.
So there's still the possibility of the carotid nausea tumors like schwannoma and neurofibroma. But
yeah, which now runs along the carotid sheath?
Along the carotid sheath, in it almost in its entire extent, we can see the vagus nerve going along it. But the other nerves are like 9, 11, and 12, which leaves off with even above the suprahyoid neck. Vagus even continues infrahyoid.
So what is the classical feature of what type of vascular displacement you will expect in a vagal? So now can you show the axial venous phase?
Yes, sir.
Yeah, here so where is the carotid artery, where is the IJV?
Yes. Here this is the carotid artery. Common carotid artery, like there is the ICA and the ECA, and this will be the like IJV, which is being pushed posteriorly.
Yeah.
And the lesion probably from vagus it can be.
Yeah.
Shall I show another picture?
Now here any other finding in the tongue because clinically you are showing something, no?
Yes, sir. There is also like atrophy of the left side of the tongue muscle, tongue.
Yeah. So what is the importance of that? Atrophy of the tongue with the neck mass.
It might be possible from the hypoglossal nerve also.
Yeah. So that is a very important thing. Clinically, patient has an atrophy, and the CT wise also it shows us some atrophy under the fat infiltration. So you have to think possibly whether it can be from the hypoglossal nerve. Okay. Yes.
And the other possible another thing is like sympathetic trunk also will be there. One second. So this will be like a fairly well-defined lesion with no significant enhancement in left carotid space, extending from almost from the left common carotid bifurcation, almost reaching till jugular foramen. And we can see the PPF parapharyngeal space pushed anteromedially. And here we can see this will be the this will be the carotid space, the IJV and the 10th nerve. You can see like coming from the jugular foramen down, and also you can see the 10th nerve almost in between the ICA. You can see it anterior to the IJV and all, and this is the ICA and ECA. So anything like coming from the 10th nerve, like it can cause the splaying of the ICA and ECA, but may not be reaching till the bifurcation. And another is, even you can see here, this will be the hypoglossal canal. This is the hypoglossal nerve and reaching till the tongue. This also shows the course almost anterior to the IJV, and also it is in the suprahyoid level, like it is showing, above the CCA, it is showing in between the ECA and ICA. So this can explain our imaging wise also, like it is playing apart the ICA and ECA and pushing the IJV, which is posteriorly.
Yeah, so how will you differentiate hypoglossal sonoma from vagal sonoma by looking at the superior extent of the lesion? So if it is a hypoglossal sonoma,
Yes,
it comes from the
like a hypoglossal canal.
Yeah, so hypoglossal canal, if it is usually extend into the hypoglossal canal, there will be widening of the hypoglossal canal. Whereas the jugular nerve comes through the, the 10th nerve, vagus nerve comes through the jugular foramen. Okay, so if you can able to, but in this case, there is no widening of the hypoglossal canal.
Yes.
Okay, only thing is there is a atrophy of the muscle is there on the tongue muscle. Okay.
And also we can see the sympathetic trunk which lies medial to the ICA. So if at all any schwannoma from the sympathetic trunk, it will be pushing the entire ICA laterally.
Okay.
But in our case, like the ICA is pushed medially, so that we can differentiate between, it might be from the vagus or hypoglossal and sympathetic trunk.
Okay.
Yes.
Yeah. So can you know some of the findings
yes,
and
sir.
the diagnosis?
Yes, sir. As this was not showing much enhancement, we have the possibility of the vascular origin, and even the paraganglioma, like carotid body tumor, is less likely because of the no avid enhancement. So the possibility
Can
of
this be a nodal mass?
tumors.
Why not a lymph node mass?
Yes, a nodal mass is still a possibility, sir.
Now, what is against or what is unusual? See, generally nodal mass, you will see some conglomerate node, or maybe at least it shows some enhancement under the central necrotic areas. And other thing is the shape of the lesion. See, this shape of the lesion is it's somewhat oblong, whereas the nodal mass won't be having this type of shape. Will define the things. So, and we are not seeing any other primary mass also. Okay, yeah.
Okay, sir. And the clinical scenario, we had the left muscle atrophy.
Yes, tongue muscle atrophy will be a very, very important clue.
So possibility of the hypoglossal nerve involvement. Actually, this was taken the FNAC. It came as like schwannoma, and intra-op also, like it was around the hypoglossal nerve. It was finally diagnosed as like left hypoglossal schwannoma.
Yes.
And then I'll proceed for the next spaces.
Quickly you can show the review. Yeah.
Yes, sir. Next spaces in general, we have the cervical fascia. We will be dividing into like superficial and deep cervical fascia. Superficial will be the most superficial part. Underneath it, like the platysma will be there. It will be just having the loose connective tissue and the superficial nodes. Then we have the deep cervical fascia, which has again the three layers: superficial, middle, and deep. This superficial will be enclosing the two muscles, like the anteriorly like sternocleidomastoid, and posteriorly we have the trapezius muscle, and also two glands also it will enclose: parotid and submandibular gland, the superficial part of the deep cervical fascia. Next is the middle layer. This will be like the muscular. It will be like around the strap muscles, and also visceral. That means around the thyroid gland and the pretracheal fascia in the visceral space. And coming to the deep part, it will be like alar fascia and the prevertebral fascia. And then coming to the spaces of the neck per se, like we can see that initially one is like pharyngeal mucosal space. For example, we can divide into suprahyoid and infrahyoid. These are but the spaces which extend through both supra and infrahyoid neck or carotid space through and through, and retropharyngeal, perivertebral, and posterior cervical space. Suprahyoid, we have the parapharyngeal, pharyngeal mucosal, masticator, and parotid. In brief, if you see, this will be the pharyngeal mucosal space. So the main thing is in the head and neck tumors, first is we have to locate the origin of the tumor from which space, and then we can apply the clinical features and the characteristic imaging features and put up the differential diagnosis. Initially, when coming to the pharyngeal mucosal space, we have the mucosa, so possibility of squamous cell carcinoma, and then we have the Waldeyer's ring, so like lymphomas, and any we have the tonsils there, tonsillitis, abscesses, and all. And then laterally, if we come, this will be the masticator space, which includes the masseter muscle, lateral and medial pterygoids, and the mandible. That is the posterior body and ramus of mandible. So we can get the osteomyelitis of mandibles and any sarcomas from them, and also mainly dental abscesses, all the possibility. And we come to the parotid space, has the parotid and the superficial and deep divided by the facial nerve. And we can get the parotitis and neoplastic is pleomorphic adenoma as a possibility. And then in between these, we have the parapharyngeal space. Actually, this is the most important one, which will help us identify the origin of the tumor from which space. So for example, if the tumor is coming from the masticator, it will be pushing because the parapharyngeal space having predominantly fat and some minor salivary glands. So the fat will be pushed posteriorly, posteromedially. If it is parotid space lesion, it will be pushed medially. If it is like the perivertebral, it will be, or the carotid space, it will be pushing it anteriorly. So such way it helps us the origin of the tumor. And then we have the perivertebral space. And then we have the retropharyngeal space, which are the common thing. It can be like abscesses. And it will almost reach up to the mediastinum also. And then when we come to the next, this will be in this coronal, this will be the parapharyngeal space. This will be the parapharyngeal fat we have. And this is the masticator space, masticator spaces. And then this will be the submandibular space. And then, for example, like few examples, like this will be the involving the pharyngeal mucosal space, the tonsillitis. And then there will be like sublingual and submandibular space. We have the, like for example, ranula and plunging ranula. If any obstruction of the salivary sublingual gland duct, it will be ranula. If it like ruptures and extends into the hangs into the submandibular space, it will be like a plunging ranula. And then we have the visceral space where the tracheoesophageal groove that encloses parathyroid glands. So parathyroid adenoma and any lymph node. And then recurrent laryngeal nerve. From that you can get the schwannoma. And then squamous cell carcinoma of the larynx and hypopharynx. From the thyroid lesions and an epiglottitis are a possibility. This is one of the retropharyngeal space showing the abscess, this one. And then this is the parapharyngeal space where we can see the fat. This is a fat. And then this is one of it, like parapharyngeal space has mostly fat and also some minor salivary glands. If at all you see a lesion which is surrounded entirely by fat, that means it is per se arising from the parapharyngeal space. So it may be some benign mixed tumors are there from the minor salivary glands and all. And this is one of the picture of, this is the fossa of Rosenmuller, like case of nasopharyngeal CA. This is in brief about the neck spaces.
Yeah,
Thank you,
so
sir.
thank you, Dr. Ritesh. So nicely covered the different neck spaces. So that is it. So we had three cases. First case of prevertebral soft tissue no, mass or prevertebral no, soft tissue widening, and common things are the abscesses and hematoma, but our case was a lipoma, and based on the density we should able to differentiate the fat content from the soft tissue content. Second case of sphenoid sinus mass. So you should know the DD of any tissue appearing bright on T1 weighted image, dark on T2 weighted image. These are all very, very important. And our case turned out to be fungal mass, fungal rhinosinusitis, one of the benign version. But sometimes the fungal infection can be very aggressive, so they are called invasive fungal sinusitis, which can invade the bones and all, whereas the allergic fungal sinusitis usually won't cause so much of bone destruction and they are not very aggressive. And the third case was hypoglossal sonoma, which is one of the rare entity. With that, I thank you all. Thank you, Venu sir, for giving us the opportunity.
Okay, thank you very much.
I think there are no queries from the audience.
Now, one thing, can I ask one thing?
Yes, sir. Yeah.
Now, one funny thing now. Regarding the first case, lipoma. So you said it is in the retropharyngeal space. Okay. So if it is in the retropharyngeal space, but at the same time, this is seen extending down up to the level of D4 vertebra or up to the level of carina.
Yes.
So my question is, the pharynx is actually stops at the level of C6. The hypopharynx stops at the level of C6. Then why it is still called retropharyngeal space? Number one. And second question is, what is the lower limit of the retropharyngeal space?
Yeah. So that is little unusual. Even we are also wondering why it is extending so much down into that. I don't know.
No, Dr. Jidesh is there, and then he can answer.
It was Dr. Sanidhya. Sanidhya, you read about it?
Yes, sir. So basically what the literature tells is the inferior extent can vary from C7 to D6, sir. So depending, so as sir told, like the pharynx, the lower part we tell till cricoid and till C7, but the retropharyngeal space basically is divided into two parts, sir.
Yeah.
One is true retropharyngeal space and one is danger space. So the danger space is what is the posterior most smaller element which can extend up to the posterior mediastinum as well, sir. But it's very difficult to delineate on imaging. That is what literature tells.
One thing, there's a small correction. There's a small correction now. So basically, actually, there in the posteriorly you can see three spaces, which is bound by the deep cervical fascia. That is, one is the prevertebral space, second is the danger space, and third is the retropharyngeal space. So from posterior to anterior, prevertebral space, danger space, and retropharyngeal space.
Retropharyngeal, yes.
Yeah. So the prevertebral space actually caudally it extends up to coccyx.
Coccyx.
Okay.
Yes, sir.
As long as the vertebra is there, it is there.
Sir.
The prevertebral space is there. Okay. Then there is no confusion. And the danger space stops not at the posterior mediastinum. Danger space stops at the level of the diaphragm. Okay. And what about the retropharyngeal space? As you said, the retropharyngeal space can extend anywhere between C6 and D4 vertebra. Okay. So that is the lower limit of the retropharyngeal space. So only thing, the retropharyngeal space is same. Up to the pharynx, we can actually call it as retropharyngeal space.
Retropharyngeal,
you can call it as retroesophageal space. That's all.
Okay, sir. Yes, sir.
It is the same space.
Yes, sir.
So the caudal limit of the retropharyngeal space is D4 vertebra. Maximum it can go up to the D4. So in the first case, actually, the lesion was seen extending up to D4. So there is no problem. So it is actually no, just I want to know whether, I mean, just want to clarify that the retropharyngeal Up to the level of pharynx, you can call it as retropharyngeal, and below which you can call it as retroesophageal.
Retroesophageal. Yes.
That's all. Anatomically, it is same.
Yes. Yes.
Thank you. Thank you.
Yeah. So with that,
Thank you,
we'll.
Rajesh.
Yeah. Thank you, sir. So with that, we are come to the end of the today's session. Is Soumya, you can close the session.